Morning and warm welcome to Online Anaesthesia, postgraduate teaching program and Zoom platform, sponsored by Akrulla and hosted by Euphrates and simultaneously aired by Anaesthesia TV. Today we are hosting Critical Care Series 4th week. With that, we are completing 6 months of our online anesthesia program successfully. I have to thank the viewers at this juncture. Today, the topics are surveying sepsis guidelines, what is new and what is obsolete by Dr. R Ebenezer. That will be followed by responding to trauma, your priorities in the first hour, resuscitation of fluids and transfusion by Dr. Devachandran Jayakumar. Today's session is coordinated by Dr. Rajesh Jayaprakash. Over to you, sir.
Good morning, everybody. Welcome to the session on critical care. We have had a wonderful 6 month time with you all postgraduates. I think many of you would have really got benefited by this. So in our critical care series today, we have two interesting topics. The first one is on surviving sepsis campaign. For that, we have eminent speaker, Dr. Ebenezer, who has come with us today. He has done his MBBS in Madurai Medical College, completed in 1999. And he has done his DNB in anesthesia in Meenakshi Mission Hospital in 2007, where I had a brief acquaintance with him. And after that, he has gone on to do so many things in his critical care thing. He has completed his IDCCM, IFCCM, EDIC, and he has worked with many prominent hospitals, both in Madurai and Chennai, including Sundaram Foundation. And at present, he is the senior consultant in Vanagaram, Chennai, in critical care. He has had excellent publications to his record till now. Over to Ebenezer, sir. We are eagerly waiting for your lecture. Welcome, sir, and over to you.
Thank you, sir. Thanks a lot. And I would once again like to thank all of you for having me here for this particular talk. So without much ado, I think we will one second. Okay, I think is it visible and am I audible?
Yes, sir. Both visible and audible.
Okay. So the next 1 hour, we are going to deal with a very, very, very important aspect in clinical practice, which we see day in and day out in our intensive care units, sepsis. I think there have been many guidelines which have been coming for the past 2 decades, 2008, 2006, 2012, 2016, and now 2021 also. So there has been a lot of changes in these guidelines, but as in this particular talk, I would like to take it along with the clinical aspect of it, how we have to go about treating a patient with septic shock. And I would like to thank my co-consultant, Dr. Ramesh Venkatraman, for the slides. Thank you, sir. And let's go ahead into the topic. Now, when you think about sepsis in ICU, we can go through this particular talk under certain important headings. How do we define sepsis? The principles of management. How do we recognize sepsis at an earlier stage? How do we resuscitate a patient with septic shock? And early appropriate antibiotics as a linchpin of therapy, and organ support. As you do all these early recognition, early resuscitation, and appropriate antibiotics, how do you support the various organs? As well as salvage therapy. Sometimes you have to salvage the patient when the patient is not doing that well. So finally, we will go to some take-home points, which will also be an important aspect in this particular talk. Now, as you all know, sepsis previously was defined as a possible or probable infection plus any two of the following. Either the patient will have temperature, there can be very high temperatures or sometimes even hypothermia, tachycardia, tachypnea, and leukocyte count, which is at the higher level, or a leukopenia. So this constellation of signs and symptoms is called as SIRS. So when it is in addition to a probable or a possible infection, the terminology of sepsis was defined in the earlier definition. And when you think about sepsis and severe sepsis and septic shock, this is how it evolved. So when you think about severe sepsis, there will be sepsis, as I told you, SIRS plus infection, plus organ dysfunction, hypotension or tissue hypoperfusion. And in septic shock, there will be an evidence of abnormal perfusion and hypotension will be there despite adequate fluid resuscitated. So you have given adequate fluids. In spite of that, if the patient is hypotensive, the terminology of septic shock comes. So now there are three trimodal distribution here, in the sense it is sepsis, severe sepsis, and septic shock. Now what has happened is severe sepsis has now become superfluous in nature. We have taken away severe sepsis from the definition part also. And when you think in terms of resuscitating fluid bolus, it is usually 30 ml per kg of crystalloid. So the newer perspectives are, first of all, you should understand sepsis is not an illness, but it is a syndrome. So you have to distinguish it from a straightforward infection. So it is not only an illness per se, but it is a syndromic manifestation where it is decided upon by the multifaceted host response. There is an invading organisms, how well the body responds to that. That is very, very important. And apart from that, SIRS criteria, if you look at SIRS criteria, it only focuses on inflammatory excess. For example, if you're looking at temperature, if you're looking at heart rate, there are so many conditions apart from infection, apart from sepsis, where this will be at the higher level. For example, if a patient post-operatively, he can have a fever. That doesn't mean that the patient is in sepsis. Patient can have severe pain, which can manifest sometimes as tachycardia or sometimes as tachypnea when there's a major laparotomy surgery has been done. So only SIRS criteria alone does not mimic infection or sepsis. Pancreatitis is an inflammatory state. Initially, it is very, very sterile. There is a strong inflammatory response at the earliest stage. So primarily based upon that, you can't say it is infection. So that is where they decided to segregate, decided to differentiate SIRS versus infection versus sepsis. So slowly SIRS is becoming obsolete. We are moving SIRS out of the picture. I hope you understood this particular important point. So as I told you, sepsis is not merely an infection. The culprit here is overreaction of our defense mechanism, not the invader alone, just not the bug alone, how well the human body responds to the invading bug, invading or inciting stimuli, inciting trigger, how well we respond to that, that will determine the reaction, that will determine the sepsis paradigm as a whole. Okay, so it is nothing but a life-threatening organ dysfunction caused by a dysregulated host response to infection. So underline this important point, it is a dysregulated host response to infection. So how well the host responds, that is very, very important. So as I told you, severe sepsis nowadays, it is becoming superfluous. So now we have sepsis and septic shock per se alone. We have taken that away from the definition, and SIRS criteria also slowly we have removed it from the armamentarium. Okay. Now, when you think about septic shock, it is nothing but persisting hypotension requiring vasopressus to maintain a mean arterial pressure more than 65 mmHg and having a serum lactate level more than 2 millimole despite adequate volume resuscitation. The most important underlining points here is persistent hypotension despite adequate volume resuscitation, inability to maintain a MAP of more than 65 millimeter of mercury. Okay, now, so when you enter into your ICU and when you are looking at your patients in your ICU, you're doing your morning rounds, will you be able to identify people with sepsis? Is there a mechanism whereby you can identify people with sepsis? So now this is where so many scoring systems are there to identify patients with sepsis. And this is a SOFA score, which looks at various parameters, respiration, coagulation, liver, cardiovascular, CNS, renal. So you have the score and you can do the scoring. You need not do a senior nurse or the nurse in charge. They can go ahead and do the scoring system. Now, it is easily available and retrospectively also it can be scored. But what we realize is what we need is we need a scoring system whereby a screening system per se, whereby when we round on the patients, we should be able to see or tell whether there is the patient is suffering from septicemia. Some warning signs are needed. So based upon that, the quick SOFA criteria came into the picture where they looked at the respiratory rate. Suppose that the patient is tachypneic, patient is having a high respiratory rate. In your ICU, you're looking at a patient who is very, very tachypneic, and there is delirium, altered mentation, and there is a drop in blood pressure less than 100 millimeter of mercury, systolic blood pressure is there. These are all warning signs. Your antenna should raise. and you should look for evidence of sepsis, evidence of infection, or evidence of septicemia in these patients. So this is where the Quicksilver criteria comes into the picture. But again, I would like to add here, in the recent SSC guideline, Surviving Sepsis Guideline 2021, the recommendation states that you cannot use only Quicksilver criteria as a single tool for screening criteria. Single tool as a screening criteria, you cannot use it in comparison with SIRS, NEWS, or MUSE. This is the statement given by the Surviving Sepsis Guideline. So these are all there to help you. These are all there to help you screen the patients, but at the same time, your clinical judgment is also very, very important. So now, once you have assessed, once you have picked up, probably this patient is suffering from an impending septic shock. How do you go about treating this patient? Okay, so early resuscitation is very, very, very important. So our fluid therapy is of paramount importance. What fluid to give? How fast should we resuscitate a patient? And when we resuscitate a patient in septic shock, what should be monitored? When should we stop giving fluids? You can't keep on pumping fluids. When do we start vasopressors? And if at all I have decided to start a vasopressor, which particular vasopressor should I start? And what should be my mean arterial pressure target? These are all very, very important treatment related decisions which you have to make at the bedside. And for that, there are clear-cut guidelines are there. So the commonest thing, the debate is always versus a colloid or a crystalloid. What do you want to choose? Whether you want to choose a colloid or a crystalloid, the guidelines are very clear. Crystalloids are the fluids of choice. Okay, so crystalloid versus colloid, the debate is over. Crystalloid is the answer. Okay, this is a safe study which was done previously. They compared albumin versus saline volume. They compared all of its survival time, organ dysfunction, duration of mechanical ventilator, duration of renal replacement therapy, ICU length of stay, hospital length of stay, and even the crystal randomized trial also, they studied the mortality in critically ill patients presenting with hypovolemic shock, colloid or crystalloid. And what they found out was absolutely there was no difference. And when it comes to starches like hydroxyethyl starch, etc., there was an increased incidence for renal replacement therapy. And the guidelines are also recent surviving sepsis guidelines are very clear. They have moved away from starches, they have moved away from gelatins, and they are advising not to use that. Suppose you are given lot of crystalloids, they have even advocated the use of albumin as a resuscitative fluid, but they have moved away from hydroxyethyl starch and gelatins per se. So this you have to understand. So this is an important thing which you should remember. So the reason why we used to give colloid is because we thought that 1:3 ratio was there. So 1 ml of colloid was equivalent to 3 ml of crystalloid. So we were able to resuscitate a bit faster. Probably you'll be able to achieve the hemodynamics a little bit faster. But overall, if you see, there was no difference in the mortality. At the same time, there was some side effects related to renal replacement therapy in a subgroup of colloids like hydroxyethyl starch. Okay. So to summarize, colloids do not reduce the fluid requirements significantly. Hyperoncotic colloids should be avoided. And hydroxyethyl starch increases the risk of AKI, renal replacement therapy, and mortality. Okay. So the guidelines are very clear. They have moved away from starches and gelatin. Their preferred choice of fluid when you compare crystalloid versus colloid is crystalloid. Okay. So suppose now it is very, very clear. We are going to use crystalloid as resuscitation. So suppose we decide to go for a crystalloid, which particular crystalloid will you use? So this is where the next particular strategy comes, whether we have to use a chloride liberal versus chloride restrictive intravenous fluid administration strategy. And here again, I want to again emphasize the previous guideline gave a guideline which stated like you can use balanced salt solution or normal saline. But the present guideline is very, very clear. Balanced salt solution is the answer. So balanced salt solution will be the answer. So you have to use a balanced salt solution, and chloride rich fluids and chloride restrictive fluid strategy will be the ideal way to go about. So this also you should understand. So when they study the in-hospital mortality among critically ill patients with sepsis, when they used balanced salt solution, So here you can see the mortality, there is a definite decrease. So the ideal fluid of choice would be a balanced salt solution. So to summarize, I would put it as colloids do not reduce fluid requirement significantly. Hyperonchotic fluid should be avoided, like 20% albumin, etc. Hydroxyethyl starch will increase the risk of AKI, renal replacement therapy, and mortality. Please avoid hyperchloremia. Don't pump patients with normal saline. If you keep on pumping patients with large amounts of normal saline, that will result in dilutional acidosis also. So please don't keep on pumping normal saline. Go for a balanced crystalloid solution. And there are two trials which are recently coming up. One is the SMART trial and the BASIC trial. When you look at the SMART trial, that has shown a difference in the mortality. That has shown a difference in mortality around 36.5 to 43.4. But in the BASIC trial, again, there has been no difference in the mortality when they compared balanced crystalloid with saline. But again, according to the guidelines now, it is more in favor of a balanced crystalloid solution rather than a saline. So to summarize, go for crystalloids. If you have decided to go for crystalloid, go for a balanced crystalloid solution. Okay. So how fast do I give, sir? Shall I give 2 liters? Shall I give 3 liters? Shall I give 4 liters? How do I resuscitate a patient with septic shock? See, you have to bolus as fast as possible. The only places where you have to be careful is if patient is elderly with an impaired renal function or cardiac function, be a little bit careful. Otherwise, you resuscitate as fast as possible. And remember, you have to look for some response also. You look at the heart rate, you look at the BP, whether the tachycardia is settling down, whether blood pressure is stabilizing, whether the urine output is picking, and perfusion is improving. All these things you have to look at. All dynamic measures also have to be come into the picture. Apart from that, if you're comfortable with an ultrasound, you can always look at the IVC size. You can look at the collapsibility. You can look at the left ventricular size. You can see whether it is underfilled or not. You can look at the ejection fraction. You can look at the cardiac function immediately. So based upon that, you can bolus as fast as possible. Usually the bolus is at 30 ml per kg. That is the bolus dose which has been advocated. Okay. And as we resuscitate nowadays, what we do look at the lung ultrasound. We look for the B lines to see whether we are over resuscitating. These are things, these are adjuncts which will help you in your clinical practice to guide fluid resuscitation. Okay. So central venous, very, very rarely we use it. So we can avoid this slide. And now this is a very, very important slide. See, hospital mortality is there in the y-axis. And here the type of fluid resuscitation is there in the x-axis. Now, your initial fluid resuscitation, if suppose it is very, very adequate, and post-resuscitation fluid management is conservative. Okay, you find that the mortality rate is very, very less. But suppose initially you don't give the patient fluid at all. Patient is septic patients, whenever they come in, usually they are tachypneic. So when a patient is in respiratory distress, some doctors, junior doctors, they might feel that it is very, very risky to give fluid. Otherwise, it might precipitate pulmonary edema. So you should understand that tachypnea is primarily because of the underlying acidemia in the patient. Okay. So for the, suppose if you don't give fluids initially, and then later on, if you're going to pump in them with fluids, the mortality is going to be very, very high. So remember, usually the guideline also nowadays is very, very clear. See, they do advocate a restrictive fluid strategy for the first 24 hours, but in the initial first 3 years, probably initial early phase, you can go for an aggressive fluid management. In the sense, adequate fluid therapy can be given. So give your fluids and then you hold your horses. Very, very important. That will reduce your mortality on the whole. So because this is an important picture which clearly tells you when you're resuscitating, sometimes we forget time. At the same time, we forget how much of fluid we're giving. Registrar after registrar keeps pumping the patient with IV fluids. Finally, this will be the picture. There will be edema across the body, myocardial edema, hepatic congestion, gut edema. All of this will complicate the picture as the patient is being weaned. Suppose the patient is on a ventilator, more and more fluids initially, if are pumped in an abnormal amount, all of that have to be taken out also. So these things will also have an important aspect. So try to be very, very careful how you resuscitate your patient. This is a beautiful slide of the fluid paradigm, balance paradigm, how it happens. So as I told you, the initial phase will be a resuscitative phase. And then once it comes to the maintenance phase, look at the urine output. If the urine output is adequate, just slightly above that, you try to keep giving your fluid. So try to maintain an even fluid balance. Initial aspect will be a guided fluid resuscitation. And after that, sometimes we have to remove the fluid also. See, suppose a patient is on a ventilator. He has come in with septic shock. He had an acute pyelonephritis, endotoxic shock, and you resuscitated the patient beautifully. But you had to intubate the patient, and the patient is on the ventilator. And later on, the patient went for a DJ stenting over, and patient has come back, and patient is improving very well. After 2 days, you're seeing patient is superb. But now you want to extubate the patient, but you find that there is a positive balance of close to 8 to 10 liters. So that much amount of fluid has gone in. So now, when you're going to extubate and you're going to wean, as you come down on your pressure support, you're seeing that the patient is becoming slightly tachypneic, but you're not able to, but all other parameters are improving. Blood pressure is great, no fever, patient is not toxic. So probably the patient is having a lot of fluid in the body. So at those particular time, you might have to use a small dose of Lasix to remove the fluid and then see to that the patient is off the ventilator as early as possible. So resuscitation, maintenance, and removal or recovery is very, very important in fluid management. Okay. As I told you, always my residence registrars ask me how to assess the response. So there are various ways. You can use your ultrasound, you can use the vena cava size. And if suppose you have an arterial line, you can use the passive leg rising test and see whether the patient is responding to your fluid management strategy. So, but always I do believe that after the initial resuscitation, try to give aliquot of fluid bolus and see how the patient is responding. So there is no reliable one single test to predict fluid responsiveness or unresponsiveness. It is a dynamic measure. You have to combine many measures, but remember IVC size, positive passive leg rising test, guarded fluid challenge, they will all help you to assess the fluid responsiveness. At the same time, if you're comfortable, as I told you earlier, you can use a lung ultrasound. You can see the lot of B lines are there. All of that will indicate an alveolar interstitial edema. So try to see to that you don't pump in too much of fluid. In the earlier SSC guidelines in 6, 8, and 12, 2006, 8, and 12, this was a landmark trial, the reverse trial, where they gave some guidelines of a CVP, of a mean arterial pressure, of an SCVO2. Based upon that, resuscitation was being done in those particular days. Now still the map holds good, but after that we have evolved and we have come over a long distance. Okay, so coming to this particular side of lactate and sepsis, I think all of you will agree lactate is a surrogate marker. So, and usually in shock, lactate levels start going up. And what does the guideline state now? So whenever there is a high lactate level, they do advocate checking the lactates as you resuscitate the patient to see whether your lactate levels are coming down. So, but remember, hyperlactatemia can be independent of tissue perfusion. Hyperlactatemia does not indicate that only patients who are having tissue hypoperfusion will result in high lactate levels. There are so many other mechanisms also by which you can have high lactate levels. Okay, so these are all important things that you should understand. But as per the latest guidelines, checking lactates regularly probably will be a guide for your resuscitative strategy when a patient is having a high lactate level. So when do you start these vasopressors? So you have resuscitated adequately. So you have chosen a crystalloid, you're given a balanced salt solution, and you have given a bolus of 30 ml per kg. You have started resuscitating. As you're resuscitating, you're using your tolerance, etc. You're finding out whether a patient is tolerating everything. But in spite of that, patient is hypotensive. That is a time where you have to go for starting a vasopressor. So once you decide to start a vasopressor, the next question is, what should I start? So as you all know, there are so many vasopressors: norepinephrine, dopamine, epinephrine. So many studies have been conducted, but I would like to state that the vasopressor of choice would be norepinephrine. The first therapy of choice would be norepinephrine. Absolutely, there is no role for renal dose of dopamine in medico-surgical ICUs. We don't use it. Still in cardiothoracic ICUs, some cardiac surgeons are still fancy low dose renal dose dopamine to improve the urine output. Exactly, that will only improve the urine output. That has got nothing to do with your hemodynamics. Okay, so as you know, when you look at norepinephrine as the first choice. In spite of norepinephrine, if the blood pressure is not improving, then you will be introducing vasopressin. That will be the second drug of choice. If norepinephrine and vasopressin is not able to pick up the blood pressure, then you have an option of introducing epinephrine. Okay, suppose that the patient is having a cardiac problem. Suppose the patient is having a poor LV. In spite of that, there is an additional insult of a septic insult. There is a myocardial dysfunction along with septicemia. Probably a dobutamine and norepinephrine combination could also be useful. As you know, norepinephrine is a severe vasoconstrictor. Sepsis is a vasodilatory shock. So it will vasoconstrict. As a result, blood pressure will improve. At the same time, dobutamine will have a good cardiac contractility effect. Dobutamine can also cause some element of vasodilatation, which is offset by the norepinephrine. So in cardiac patients with septic shock, probably you can use a dobutamine or a norepinephrine, or you can go for an epinephrine itself. Absolutely, there is no need for a central access every time. Okay. The recent guidelines are also very clear. Suppose you're resuscitating a patient, that is when you're going to start a Vasopressus, there is no need for you to place a central line and then start Vasopressus. You can start a Vasopressus in the peripheral line itself. Okay. And the question is, how much dose can I go with the peripheral line, sir? See, there is no hard data to say, but at the same time, half max dose, whatever max dose you're allowed, in that half max dose can be given through the peripheral lines. But beyond that, there is no, see, sometimes what happens, even with that peripheral line with a half max dose, patient improves, BP stabilizes, and probably you'll be able to avoid a central line in those patients. So that is an unnecessary foreign body and unnecessary nidus for future infection, which you have prevented. So central access is always not mandatory when you're resuscitating these patients. Okay. BP target, as I told you, a mean arterial pressure of 65 millimeter of mercury. And antibiotic therapy is very, very important. So when you think about antibiotic therapy, you have to maximize the outcome. So for that, when you start antibiotic, timing is very, very important. And what particular antibiotic, it should be very, very appropriate. And how do I give the route, the access, at the same time, the delivery system. These are all very, very important. So now previous guidelines, they were telling that as early as possible, within 1 hour, we should start the antibiotic. Now in the latest guidelines, if there is a probable or a definite source of sepsis with septic shock, absolutely clear, you can start the patient with less than 1 hour, you can start the antibiotic. Okay, no issues. But suppose if there are some other possible causes for the patient's clinical condition and you're not sure that it is sepsis, if the patient is not in shock, you can still wait. You can reassess, you can see, you can evaluate, and there is a window period of 3 hours. Suppose the patient is in shock, then probably within 1 hour would be the ideal duration. So this is one important thing which you should understand when it comes to the newer guideline. So now once you've decided about antibiotic, there are certain things you have to understand. So this particular graph clearly proves that the time to antibiotic decides about the hypotension effect also. Time to antibiotic will decide about your time to antibiotic decides about the mortality also. So more and more patient is hypotensive, and more you allow patient to be hypotensive and the patient is not on an antibiotic, automatically the mortality also will shoot up. So this is effect which is sustained across gram positive, gram negative, and Canada. Across any particular, all particular organisms, earlier you start an antibiotic, that will be earlier you start an antibiotic and antifungal, that will give you the best possible result. Okay. So this is how, and you have to reassess for de-escalation daily. So this is one important point which you should understand. See, you cannot set a fixed time frame that I'm going to give this antibiotic for 14 days, 7 days like that. You have to de-escalate daily. You have to look at your culture, how the culture is coming. Suppose you started the patient on a meropenem, and then it comes as very sensitive to ertapenem also. You can de-escalate to ertapenem. Suppose it is sensitive to cephalosporin sulbactam, you can come down to cephalosporin sulbactam. And PCT guidance, procalcitonin. What does the new guideline tell? So new guideline tells you to use PCT as a tool to guide de-escalation. Yeah, serial PCTs are advocating. They agree with the idea of using PCT when you're going to de-escalate an antibiotic. Okay, this is very, very important. And another important aspect which I want to discuss is appropriateness of antibiotics is very, very important. You have to give the appropriate antibiotics for the appropriate spectrum. Okay, that is also important. Now, based upon this, there is one guideline which I would like to go, the newer guideline. See, suppose there is a high possibility in your ICU of a multi-drug resistant organism. Okay, then they advocate in patients with septic shock with the possibility of MDR growth, then probably you might have to go with 2 gram negative covers. Okay, you have to go with 2 gram negative covers. Suppose the possibility is not of an MDR or growth, then you can stick with 1 gram negative cover. At the same time, you feel that there is a possibility of a gram-positive infection or an MRSA infection. MRSA very rarely we see in our place, but in Western countries it is pretty common. So then you have to supplement with a strong gram-positive cover, strong MRSA cover. So along with meropenem, probably you have to add a teicoplanin or a vancomycin. So this is very, very important. So appropriateness of antibiotics is also very, very crucial, because sometimes you will miss the boat, sometimes you will miss a bug. And suppose if you have a superadded infection, sepsis, in the sense the patient is on the ventilator for many weeks in your ICU, then there is a chance of many different bugs getting into the picture. There can be some bugs which will not be covered by some antibiotics. For example, colistin, that is a very, very high antibiotic, which I think all of you will be knowing, you will be using, etc. But colistin does not cover Burkholderia, it does not cover Serratia, it does not cover Stenotrophomonas multifida and Citrobacter. These are some bugs which it does not cover. So suppose if a patient repeatedly the patient is going in for sepsis and you feel that the patient is not improving, you have to be very, very careful. Okay, colistin alone is probably not the only answer which will cover everything. So probably there you might have to add another drug like levofloxacin or a bacterium, which will cover all these smaller bugs, which can also prove to be very, very deceptive and very, very lethal. So appropriateness of antibiotics is extremely important. Okay. As I told you, for appropriate antibiotics, adequate time. Okay, adequate time. Decide about the time very carefully. Optimally, if you give, the best outcome is achieved. Okay, that is also an important point. And always you have to guess right. Your ICU antibiogram is very, very important. The antibiogram profile in your ICU will decide how you are going to treat. For example, in a hospital which is 5 years old, you will not be seeing that many MDRO bugs. But in a hospital which is 30 years old, you will be seeing mostly fungal infections in MDRO bugs. So you have to guess right based upon the antibiogram profile of your ICU and then hit broad. Don't hesitate. When you are initiating antibiotics, try to broaden the spectrum in a septic patient in ICU. If you're going to go with a narrow spectrum, you will lose the patient. Hit broad and hit hard. Never hold back your horses. The initial loading dose, irrespective of your creatinine levels, it should be at a higher level. So try to hit hard earlier, and then you try to de-escalate based upon your culture sensitivity report. That is also very important. So as I told you, there are some special states where you have to understand. For example, pancreatitis. Carbapenems will have maximal penetration. Based upon that, you have to use it. So if you look at pneumonia, okay, linezolid better than vancomycin. You cannot use daptomycin in pneumonia because it will be inactivated by surfactant. And tigecycline, absolutely, it has got very poor efficacy in bacteremia. So when a patient is suffering from bacteremia, you cannot be using tigecycline in those patients. So this you should be careful. And similarly, urosepsis also, very minimal concentrations. So these are certain things that you should understand. And based upon that, you should tailor your antibiotics so that you get the best possible results. Okay. So delivery also should be very, very, very important. Nowadays, we are going for a continuous infusion. We don't give bolus. Okay. So use them. And coming to steroids, apart from antibiotics, I think now the new guidelines are advocating usage of steroids up to 200 milligram per day when a patient is having hypotension on Vasopressus therapy. Okay, this is one important point which you should understand. Okay, and organ support. We don't transfuse patients with blood very rapidly and all. Okay, so we are very, very conservative in the sense, restrictive. And for us, a hemoglobin of 7 is equal to 9 gram. So unless otherwise patient is having a severe coronary artery disease problem or some acute coronary syndrome, we hold back our blood transfusions. We use it very minimally. So this avoids transfusion related acute lung injuries and transfusion associated other problems. Everything we're able to avoid that. Okay. And coming to mechanical ventilation in newer guidelines, this is also one important point. When it comes to mechanical ventilation, low tidal volume ventilation strategy you have to use. Now recently HFNC has been also been advocated versus NIV for mild sepsis induced oxygenation problems. Okay, you can use it. So apart from that, when you're thinking in terms of other strategies, veno-venous ECMO, the new guidelines has recommended veno-venous ECMO when a patient is suffering from severe ARDS not responding to conventional therapy. Another thing is when a patient is having moderate to severe ARDS, they have advocated a high PEEP strategy. Okay, these are all some guidelines which they have been formulated, and the new guidelines have come through. You have to go in detail later on. Okay, and glycemic control. See, we don't go for a tight glycemic control at all. So please try to control the sugars. Try to avoid glycemic variability. That is more important. Okay, and CRRT is being used when a patient is having severe hemodynamic instability in presence of septic shock. So the dose is 25 ml per kg per hour. This the new guidelines is advocating. So renal replacement therapy is advocated in these particular conditions. Okay. And any other thing, for example, absolutely there is no role for immunoglobulin. Okay. All these experimental therapies absolutely have no role. IV vitamin C. Okay. Last few years, people are using IV vitamin C right and left. The new guidelines is very, very clear. IV vitamin C, they're against it. They have taken it away. Okay, and blood sugar target, etc. I have told you. Early enteral nutrition within 48 to 72 hours. So as early as possible, you have to feed the patient. You know very well, gut translocation leads to sepsis. As a result, you have to avoid that. You have to give fuel there. So please try to avoid that. Okay. And DVT and stress ulcer prophylaxis. Stress ulcer prophylaxis is advocated. And when it comes to DVT, pharmacoprophylaxis is more than enough. Low molecular heparin is preferred over unfractionated heparin. At the same time, there is no need to combine mechanical prophylaxis with pharmacoprophylaxis. Okay, only pharmacoprophylaxis is more than enough in these patients. Okay, remember that. And lot of blood purification techniques are there. I'll just put a few words. So all of you know that blood purification techniques is a method by which they try to remove the cytokines. And maybe they think that they are reducing the inflammatory response. As a result, they feel that probably the patient would do well. But what does the literature state? Okay. As you know, when you think about the cytokine storm, there is a pro-inflammatory phase and an anti-inflammatory phase. So there are good cytokines and bad cytokines and ugly cytokines. Okay. So suppose if you are using filter therapy and you're removing the cytokines and in a way you're reducing the inflammatory response, sometimes you'll be removing the good cytokines also. This can result in a state of immune paralysis later on. So that when a patient develops repeat sepsis, etc., the patient sinks very, very fast. So cytokines storm and cytokines, they are a double-edged sword. So you have to be very, very careful when you deal with this particular group of molecules. Okay. The Euphrates trial was a landmark trial which clearly proved that there was no difference in the mortality. And the surviving sepsis guideline of 2021 has clearly told that polymyxin B hemoperfusion should not be used for septic shock. And they feel that it has got no effect. It has got no mortality benefit. And just for, since all of you are postgraduates, you should know what are the three different types, three major types of filter therapies, which we did use 2-3 years back. One is the toramycin, and the next one is the oxyrus, and the other one is the cytokines, cytosorb. Cytosorb is one thing probably most of us used it. And very rarely oxyrus and toramycin we have got our hands on. So when you think in terms of cytokine removal, cytosorbs, endotoxin removal, tora and oxyrus. So toramycin will remove the endotoxin. So this I have used in some burns patients. Some patients it did help, but we don't have any proof that it works on a large scale of patients. Cytosorb routinely we used it and it removes cytokines. Oxyrus will remove both endotoxin as well as cytokines. Again, I'm stressing the fact that these are all there in the market. These are all being used extensively in Japan, South Korea, etc. But very, very clear, the guidelines are very clear. They're against the use of these particular filter therapies, and charcoal and polymyxin heme adsorption has been taken away. Okay. So this you have to, how the people will ask, when should I use it, sir? It is of no use if you're going to use your filter therapy when a patient is moribund and already when the patient is in 3 inotropic support. Ideal time would be when a patient is in septic shock, impending septic shock, your inotropic support is climbing, and when your endotoxin assay level is 0.6 to 0.9, that is the time probably there is a role for these filter therapies. Small subset of patients, but again, these small subset of patients might do well even with your regular antibiotics and fluid management and source control. Okay, so clearly there is nothing to say that definitely that a role for filter therapy. Okay, so these are the bundles. You can go through the bundles. Very, very important. 6-hour bundle, 3-hour bundle, all of these are there. and source control is very important. So whatever you do, source control is very important. If there is a perforated peritonitis, you have to control the source. Then only your antibiotics, your fluid resuscitation, everything will help you. So otherwise that nothing is going to happen. This was the 1 hour band which came through, and 5 important things they looked at. They measured the lactate level. They obtained the blood cultures before administering the antibiotics. They administered broad spectrum antibiotics, and 30 ml per kg of crystalloid was administered rapidly as a fluid bolus, and Vasopressus was started simultaneously. Okay, there are some pros and cons for this particular strategy. So usually within 1 hour, very rarely senior people, senior docs will be seeing these patients, and mostly this will be decisions will be taken at the enteral level. And suppose if it's a trained ER doc, trained person, he will be able to differentiate. But otherwise, when you blindly follow this, there could have been irrational use of antibiotics also. So this you should understand. So you have to take it with a pinch of salt. So absolutely, the polymyxin B hemoperfusion now has been taken away. This is a slide which I took from a Japanese study. You can see what and all in Japan they use. They use antibiotics, they use IV immunoglobulin, antithrombin 3, thrombomedalin, so many things they use to reduce their mortality. But absolutely, there is no literature to support that, no RCTs to support that, and no international guidelines from the Western world to support that. But again, sometimes you may have to look eastward also. So take it with a pinch of salt. Maybe for the correct subgroup, correct subset of patients, still it holds good. But of late, we are not using filter therapies. So to conclude, again, I would like to stress early recognition is very important. Septic shock doesn't mean that patient has to be hypotensive. Very, very important point. BP might be 170, but if the patient is tachycardic, elevated lactate levels, features of sepsis, the patient might be having an underlying abnormal hypoperfusion, that per se indicates that the patient is in septic shock. So you have to look for organ hypoperfusion. Fluid resuscitation, absolutely, there is no need to go for colloids. Crystalloids are very good. They are the wonderful fluids. You can use them. 30 ml per kg will be the bolus dose of crystalloids. Please try to avoid hyperoncotic colloids and chloride containing fluids. Please, you can try to avoid. The recent guidelines have advocated albumin only when you have used large volumes of crystalloids, and in spite of that, you're not able to, you need to give some fluids. Probably you can try that. Hydroxyethyl starch, gelatins, starches, all of this have been taken away. You have to monitor the response and tolerance. Very important. Look at the bedside, look at the heart rate, look at the blood pressure, look at the urine output, look at the capillary refill time. I forgot to tell you about this. The latest guidelines is also looking at the capillary refill time also. The Andromeda Shock trial has looked at it. So they want to have a look at the capillary refill time also. That also they're asking you to have a look and see how your resuscitation is progressing along with your serum lactate level measurements. Okay. So CVP, SCVO2 lactates have their limitations. Dynamic measures are very important. So dynamically, you have to assess the fluid responsiveness. For that, of late, a good understanding of the ultrasound echo, that is also very, very important. Apart from that, passive leg raising test and arterial line is very, very mandatory. It's of great use when you manage a patient with septic shock. And next one would be Vasopressus. You have to use norepinephrine would be the first choice. As I told you, no renal dose of dopamine. Please don't wait for a central line to start a vasopressor. Start through a peripheral line. Sometimes you'll be able to stabilize the patient and even avoid a central line. First dose antibiotic as early as possible within 1 hour of shock. Please do cultures first. Don't delay cultures. Try to take the cultures as early as possible. Whenever you're doing cultures, 3 bottles of culture or 2 bottles of culture is needed, and there should be totally 4 bottles, 2 sets of culture or 3 sets of culture. So either there should be 4 bottles or 6 bottles, and 2 bottles of aerobic, 2 bottles of anaerobic, and each bottle should contain 10 ml of blood. If you take 40 ml of blood and give only, you will get some growth. There is no use in taking 5 ml, 6 ml, or 7 ml of blood. Choose your antibiotic wisely, dependent upon your local ICU antibiogram. That is very, very important. And please control the source. Source control is extremely crucial. Try to control as early as possible. Try to see to that. And if you're able to do all this in a stepwise manner, you can minimize further organ injury also. And if you're able to do that effectively, and if you're able to follow through the surviving sepsis guidelines and treat the patient appropriately, I am 100% sure you'll be able to reduce the mortality in a septic shock patient. So these are all the facets of medical management which you have to invoke and involve in managing a patient with sepsis and septic shock. Please understand this and follow this. And you can even you can look at this particular you can have a look at this. I don't know whether it's visible here. The ESICM guidelines are there, which has clearly given you about the surviving sepsis guidelines. So you can have a look at this also. With this, I would like to conclude my topic. Thank you one and all. Thank you.
That was a very wonderful presentation, sir. I think every postgraduate who is in first year, they should see it before they go to their ICU postings, sir. So, this is very, very important for them to understand and look for these things in this patient. We have two questions, sir. One is on diagnosis of sepsis under anesthesia. I think probably they're asking about whether if we have already given some sedatives or vasopressus, how will the Qs of our scores be predictive?
You are asking under anesthesia, or what is that?
The question was how to diagnose sepsis when patient is under anesthesia.
Okay. See, I'll give you a scenario. For example, there is a patient with acute pyelonephritis. Okay, and the urologist is taking the patient for surgery. He wants to do a DJ stenting and he wants to relieve the obstruction. There is a stone there which is also causing an obstruction, and above that there is a pyelonephritis also setting in. Now, when you take the patient into the theater, you're assessing the patient. Patient is slightly tachycardic and patient is febrile. And you look at the arterial blood gas, there's a mild acidosis also there. But otherwise, patient is hemodynamically stable. Okay. So when this patient you give anesthesia, sometimes patient is already in septic patient, they will be volume depleted without adequate resuscitation. So when you anesthetize the patient, they might land up in hypotension. But suppose volume resuscitation has been adequate, you are given anesthesia and the procedure is going on and the urologist has entered into the picture. He has stented. At that time, there is he is able to see a lot of pus draining out. At that time, there is an endotoxic shock and release of endotoxic shock. Okay. So suddenly you might be able to see a severe hypotension happening. Okay. Blood pressure might fall. And after that, there might be an increase in the heart rate. So these are all additional signs which you should look for. So probably under anesthesia, because the compensatory response, the sympathomimetic drive is masked, it will be very, very difficult for the patient to mount a response immediately. So sudden profound hypotension can happen. Endotoxic shock, when the urologist is doing the procedure, endotoxic shock can cause this, and you have to be very, very careful and you have to carefully manage. Don't panic, give adequate fluid, start the patient on some element of vasopressus, or in theater, you will be giving ephedrine, etc. And you stabilize the patient, bring the patient out of the theater. Okay, that's it.
Yeah, that was reason. I have also seen some patients collapsing after having a gallbladder infection, sir.
Yeah.
They just induce the patient, they'll crash.
Exactly.
Then the surgeon immediately told this is not just a cholelithiasis. This patient will be having some sepsis in the gallbladder, and it was true in the laparoscopy. So similarly, we can see in urology also, sir.
Yeah, if it's an uncomplicated intra-abdominal infection, it will be confined to the organ. Suppose if it's a complicated intra-abdominal infection, it will have spread beyond the organ. It will be a localized or a diffuse peritonitis. So in those patients, the chances of hypotension is very, very acute. You have to be careful. Yeah.
Now, another question is on sepsis and tetany, sir. How will we treat
sepsis and tetany? Okay,
I didn't get that.
I also see it's been a long time since it's a tetanus or tetany. What do they want?
I thought it was tetanus, but the question is on.
I will answer for both. Tetanus is one thing which very rarely we see in corporate world practice, but we did see a patient 2 years back who came in with tetanus, and we did tracheostomy. We maintained him on the ventilator for close to 12 to 14 days, and these patients sepsis does happen to these patients like any other patient who's on a ventilator for a long duration. Okay, he did go through waxing and waning of ventilator pneumonia, superadded sepsis due to lines, etc. And that is another thing. So, but sepsis and tetany, this is one thing. See, tetany manifestation can be due to some features. Hypomagnesemia, severe hypomagnesemia can cause tetany, and electrolyte imbalances can cause tetany. Okay. So you have to be very careful. In chronically ill, sick ICU patients, usually the magnesium level will be on the lower side. And hypomagnesemia per se, it can even manifest from a small anorexia, nausea, vomiting. It can even produce life-threatening cardiac arrhythmia, seizure, and tetany. Okay, so see, tetany probably I have never seen as a predominating sign in sepsis per se, but these are the various facts of ICU care relating to tetany and tetanus. Okay. Yeah.
Yes, sir. The next question is from Sarva Vinodini. She has asked, what gauge of Venflon should we use during a peripheral resection? What do we need?
See, usually what we want in the antecubital fossa, we want to put a good 16 gauge cannula we can use. Okay, in the antecubital fossa, you put a line bilaterally on both limbs. You can put a line, and then you can start resuscitating. That should be more than enough. Yeah.
There's another question from Dr. Lalit Kumar, sir. He has asked about 4 samples at the same time, and should we also take the urine culture and bronchial lavage at the same time?
See, you can't be going for the bronchial lavage immediately. See, patient is coming in with the septic shock. Patient, suppose, is into the emergency room. We are speaking about emergency room. Okay, he is coming to the ER, and there is a possibility of septic shock. In those patients, you're taking 4 sets of blood culture. Okay, and urine culture, if you feel that patient is suffering from a urosepsis or anything, you can, more than urine culture, the urine analysis is very important. So you do your urine routine and then your urine culture. Bronchoalveolar lavage only when the patient is on the ventilator and when the patient is suspecting a VAP, etc. There also we don't, as a routine, advocate bronchoscopic lavage. We don't use that. Very rarely we go for bronchoscopic lavage. We do a mini ball. So we try to take a mini ball, and through that we are able to get the collect the specimens and secretion, and then we are able to assess the organism, whatever is growing. Okay. But why I wanted to insist on the 4 bottles is people don't get adequate. See, the lab should get adequate blood, then only they will know what kind of organism is growing. If you're going to give the lab very minimal blood, then they will say no growth, no insignificant growth, and that will not give you any picture about how to treat the patient. Yeah.
And another question from Dr. Fatima. She has asked about using empirical antifungals. Say, like you told, if there is a 30-year-old ICU, that might be antifungals also. So should we fungal growth also? Should we use
empiric antifungal in the sense? See, you have to be very, very careful. See, you can't use antifungal irrationally also. Okay. For example, if there is a patient with pancreatitis, even empiric antibiotic we are trying to avoid. And in those patients also, antifungal only if there is indication we have to use. But suppose the patient is on the ventilator for a long time, and there is features which are clear-cut for invasive candidiasis, if the patient is having criteria meeting that, if the patient is having diabetes, long-standing broad-spectrum antibiotics have been used, patient is on multiple plastic devices like a central line, Foley catheter, okay, and his immunity is on the lower side. All of this you have to factor in. And suppose the patient is developing a second wave of sepsis, and then you are covering, and suppose if there is a intra-abdominal sepsis, if the patient has undergone a major laparotomy or a major colocolic anastomosis, and after that patient is not doing well, in those patients who are becoming hypotensive, definitely picturing all this together, and you feel that there could be a possible fungal infection. In those patients, probably there is a role for antifungal. And that too, when a patient is hemodynamically unstable, I would prefer to go for an echinocandin rather than a fluconazole, okay, rather than azole.
Thank you very much, sir. It was a very enlightening speech, and the doubts clarification also was very good. Thank you very much for your time, sir.
Thank you, one and all. Thank you.
Thank you, sir. I think it's time we move on to the next topic. The topic is responding to trauma, the priorities in first aid. What about the resuscitation fluids and the transfusion? To deliver this topic, Dr. Devachandran Jayakumar has come here. He has got a wonderful profile for him. It's too long. I just give a short introduction of him. He has done his MBBS from Chengalpet Medical College and has been the university topper in MD Anesthesiology in 2004 from Madras Medical College. He has completed his FRC in 2007 and EDIC in 2012. He also holds a PG certificate in medical education and evidence-based medicine. He has extensively worked both in India and United Kingdom, and he has a lot of publications in his records. And at present, he is working as a senior consultant at Kamakshi Memorial Hospital in Chennai. Over to you, sir. Welcome, sir, and over to you.
Thank you very much for the kind introduction, sir. Am I audible? And
yes, sir. You're audible,
is my
visible.
slide visible?
Yes, sir. Both
Great,
good, sir.
Thank you. Thank you. First of all, I would like to thank the organizers for giving me this opportunity. And I would like to thank Dr. Ebenezer, the previous speaker, as well, for putting me in touch with you all. It's really exciting to participate in online webinars or teaching sessions like this, especially for postgraduates. Thank you, both the organizers and Dr. Ebi. And I have to say, Ebi, that was a fantastic summary of surviving sepsis campaign, the most recent surviving sepsis campaign. I have to say, the document is pretty big. If you've recorded the session, that's probably enough. He has summarized it beautifully, and it was really crisp. Thank you for that. So my talk is on trauma. Responding to trauma, the priorities in the first hour of resuscitation. The topic that was given was fluids and blood. If I just talk about fluids and blood, I'll probably finish in 10 minutes. So I thought I will add a bit of spice and a bit of flavor to the talk. And let's see how it goes. Right. These are my disclosures, and there are some patient pictures. I have obtained consent for the patient pictures. Right. So this is the overview of my talk. We'll go through the history of trauma resuscitation and how it came about, because it is important to remember history. Varalaru romba mukkiyam. We'll go through the general principles of trauma resuscitation. It will be very useful for the postgraduates, if there are any in this meeting. We'll talk about shock, especially in trauma, and we'll classify the hemorrhagic shock. We'll briefly discuss the goals of resuscitation, including controlling hemorrhage, fluids. I think Ebi has made my job easy by talking about fluids, because much of what we use in trauma is pretty similar to what we use in sepsis as well. We'll talk about blood products, some medications that are used in hemorrhagic shock, and how we monitor the response to trauma resuscitation. Right. So let's start with the history, trauma management, the origin. This is the origin of ATLS. It all started in 1976, as old as me, in Lincoln, Nebraska. An orthopedic surgeon called James Steiner was flying in his private jet from Los Angeles to Lincoln in Nebraska. Unfortunately, he lost control of the aircraft. He was flying, so he lost control of the aircraft, and the aircraft crashed in a field near Lincoln. He was traveling with his wife and 4 children. His wife died at the scene. Of the 4 children, 3 of them suffered significant injuries, including head injury. He managed to get to a local hospital, but what he experienced was something very different. And he had to say this at the end of, the resuscitation that happened in the local hospital. What he said was, I'm just going to read it out. So when I can provide better care in the field with limited or no resources to my own children, and I received what I received at the primary facility, there is something wrong with the system. The system needs to be changed. So basically, he was able to triage his own family in a better way at the scene, and he was able to offer decent support at the scene than what the hospital had to offer. And that's when he thought, well, there's something not right here, and we need to change the system. And that's how trauma management was born. It was in 1978, the first prototype of ATLS came about. The Advanced Trauma Life Support came about in Auburn, Nebraska. So this is the history of trauma management. Prior to that, it was all chaotic, helter-skelter, non-prioritized. There were no priority. No, when you receive a major trauma victim, they did not have any priorities. After that, we started prioritizing whenever we resuscitated a trauma victim. So let's move to the next slide. This is James Steiner and his family. As I mentioned, his wife died, and the 3 of the children are standing behind him. All are still alive. right? So what are the general principles of managing a trauma victim? So the general principles of managing a trauma victim is A, B, C, D, E. So A for airway management with C spine control. Depending upon how the airway is, whether the patient is protecting their airway or not, you make a call whether you can leave them self-breathing or whether they need assisted ventilation with an artificial airway. It's important to make sure that you immobilize the C spine with a hard cervical collar, as you can see in this picture. B for breathing assessment, assess the breathing just like how you would do for any other patient: inspection, palpation, percussion, auscultation, and check saturation. And administer oxygen or provide artificial ventilation if the patient needs it. So this talk is going to be on circulation, so I've highlighted that in red. So C is for circulation with hemorrhage control. So it's important, very important to remember that without controlling the bleeding, there is no point in pouring blood and fluids and whatever you want to pour into the patient. So it's important to control the bleeding first before you resuscitate, or start controlling the bleeding and simultaneously resuscitate the patient. That's probably the most appropriate way of putting it. D for disability assessment, which is checking the neurological status of the patient and checking the blood glucose. It comes as part of D assessment. And finally, expose the patient completely, check for wounds, bleeders, etc., and make sure that you cover them back up and to prevent hypothermia. We'll talk about why preventing hypothermia is important, not only in trauma, but in any shock situation. So as you can see on the right side, this gentleman has an artificial airway. He's getting ventilated. There's a mainstream end-tidal CO2 in place. So A and hard cervical collar in place. So A and B sorted out. He has a line. He probably has been resuscitated with fluids and bloods. And I don't know whether you can appreciate this. There's a gas piece placed on the scalp. He was bleeding quite profusely from the scalp that has been controlled. That's C control. He's probably suffered a head injury, so disability has been assessed. And as you can see, he's covered nicely to prevent hypothermia. So the general principles of management in trauma is A, B, C, D, E. So my talk specifically is going to focus on C management. So C, circulation in trauma, is all about shock, hemodynamic shocks. As you all know, shock is the inability of the circulatory system to perfuse the organs or to provide oxygen and the nutrients needed for the organs and the tissues. So in trauma, it is hemorrhagic shock unless proven otherwise. If a trauma patient is in shock, it's got to be hemorrhage. You have to rule out hemorrhage before you put it down to any other cause. So that's the bottom line. So even if you forget whatever I'm going to talk about trauma resuscitation, if you remember this part, that'll be good enough. Of course, there are other types of shock that you can see in trauma. For example, if they develop a tension pneumothorax from a chest injury, they can develop an obstructive shock. The steering wheel injury specifically can cause myocardial contusion and can cause cardiogenic shock. And yesterday we received somebody who jumped off the second floor and injured their spine, and they came in neurogenic shock. These are some of the other shocks that you do see in trauma, but by and large, if your trauma patient is in shock, you have to search for hemorrhage. So where all can they bleed into or out? So it's important for you to remember blood on the floor and 4 more. So they can bleed externally. So the previous picture you saw, the gentleman was bleeding quite profusely from the scalp, or they can have an internal bleeding. The internal bleeding can be in the chest, can be in the abdomen, can be in the pelvis, and can be in the long bones. So when we talk about chest, somebody can bleed easily 3 liters into the hemithorax. Abdomen can take the entire blood volume, and pelvis can also take the entire blood volume. Long bones, quite often, we misjudge the amount of bleeding in long bone fractures. If you fracture your femur, you are likely to lose about 1.5 liters of blood if that femur is not splintered. If you suffer both bone fracture of the leg, you might lose about 750 to 800 ml of blood, and same amount of blood or same volume of blood if you fracture your humerus. So for femur, it's about 1.5 liters. For tibia and fibula, it's about 800 ml, and for humerus, it's about 800 ml. So if you have a trauma victim who is fully conscious, talking, but has a humerus fracture and left femur fracture and right tibia fibula fracture, they'd already lost 1.5 plus 1.5, about 3 liters. If when you receive them, they are already in a state of significant shock requiring transfusion. We'll talk about the classification of hemorrhagic shock and how you decide when to transfuse in a minute. So the sites of bleeding, they can bleed out and they can bleed into the chest, abdomen, pelvis, and long bones. So even if your trauma victim is not actively bleeding externally, it's important for you to remember the accidents happen at the scene. They might have bled a lot, like this gentleman at the scene. It's an avulsion, completely, degloving injury of the right upper limb. He would have lost a lot of blood at the scene. So that must be kept in mind when you resuscitate patients like this. So this lady has a massive left hemothorax with shift of the mediastinum to the right. And this is just a post-laparotomy bleeding into the stomach, but quite often during the initial assessment, when we talked about priorities A, B, C, D, when your patient is in shock, you would examine the chest, you would do an EFAST. So the EFAST will help you pick up bleeding into the chest or abdomen. You would check the stability of the pelvis, and that will tell you whether the pelvis is stable or not. And you will physically examine the lower limbs, and that will tell you whether the lower limbs and upper limbs, that will tell you whether there are any deformities in the long bones. So this is an open book fracture of the pelvis. And if this is the worst form of pelvic injury you can get, you can bleed a lot into the pelvis. The pelvis can take an entire blood volume. The simple initial management is just closing the pelvis. So close the pelvis with a pelvic binder. That will buy you some time until you get the surgeon or the interventional radiologist to fix the broken pelvis. And this is, of course, you all have seen this several times, fracture of the femur. Important to remember that one can bleed quite a lot into the thigh, to 1.5 liters they can lose from a fractured femur. Right. So that's shock and trauma. It's hemorrhagic unless proven otherwise. Right. This is an academic, theoretical, and a physiological classification of hemorrhagic shock. So the hemorrhagic shock is divided into class 1, class 2, class 3, and class 4, depending upon the amount of blood lost. If it is less than 750 ml, then it's class 1, 750 to 1500 ml is class 2, 1500 to 2 liters is class 3, more than 2 liters is class 4. You can also base it on the estimated total blood volume. So for a 70 kg male, it's roughly about 70 ml per kilo, about 5 liters. If the blood volume lost is less than 15% of the patient's total blood volume, it's class 1, 15 to 30 is 2, 30 to 40 is 3, and more than 40 is 4. If you listen to Dr. Ebenezer's talk carefully, you would have noticed that at least on 3 occasions, he mentioned that hypotension need not be present in shock. And the same thing holds true in hemorrhagic shock as well. So that was a septic shock talk, and this is hemorrhagic shock. So clearly, even here, your blood pressure does not fall until you lose about 2 liters of blood volume. So it is important to remember that you can still be in shock with a normal blood pressure, because the compensatory mechanisms kick in to maintain the mean arterial pressure to keep the organs perfused. So this is a common mistake I see people making, including consultants, not just trainees, but even consultants make this error sometimes, saying, oh, he's not in shock, his blood pressure is normal. So never equate your shock to your blood pressure. If you see a shocked person who is hypotensive, that means you missed the boat a long time ago. You are in a state of severe shock. That's how I would put it. So if you look at the physical signs that you will find in a bleeding person, your signs are all going to be normal in class 1. So it's like, you know, you've donated a unit and more of blood. That's all. That's class 1 hemorrhage. Class 2, if you think of your single femur fracture, it can still be okay. The signs can still be okay. From class 3 onwards, all your physical signs are going to be changed. If you look at the chart, the earliest one that you can pick up is the pulse pressure. So quite often, you know, missed, quite often underestimated as a tool to pick up shock. If you see the writings of the doctors in the chart, they will write, you know, thready radial, feeble pulse, etc. What that indicates is the pulse pressure. Pulse pressure is the difference between systolic and diastolic. You all know that. The first sign of shock is a reduction in the pulse pressure. If you can pick up that, then it's very easy to resuscitate a patient. Using this classification, sometimes, you know, you can decide the need for blood products. As I mentioned at the beginning itself, this is theoretical, academic, and physiological. We never, you know, of course, we do use physiology at the bedside, but we almost never see textbook descriptions at the bedside. So it's just a you know, table for you to remember whenever you resuscitate patients who are bleeding. For class 1 and 2, class 1, you probably won't need anything. Class 2, you probably will give some crystalloids and that's it. Class 3 and class 4 will definitely need blood transfusion. Right. So that's about shock and trauma, the classification of hemorrhagic shock. So coming to the goals of resuscitation. So your trauma victim comes to your emergency department. They are in the resus bay. You've done your primary survey, which is your A, B, C, D, E. You fixed A, B by intubating and ventilating, and you've recognized that the patient is in shock by looking at the vital signs, which we just talked about: heart rate, blood pressure, consciousness, urine output, pace deficit, etc. And you started resuscitating them. So what are your goals of resuscitation? So what do you want to achieve? What are your endpoints, goals of resuscitation? The number one goal is control of hemorrhage. So it's important that you stop the bleeding first before you give fluids and blood into the patient, or do it simultaneously. Stop the bleeding, give fluids and blood. If you do not stop the bleeding, there is no point in you pouring liters and liters of whatever fluid or blood you choose. It's going to continue to exsanguinate. So control the bleeding. Second is restore the lost volume. Third is do damage control resuscitation. Fourth, avoid the lethal triad. We'll talk about that when it comes to that. And the ultimate goal by doing all of this is to improve organ perfusion and tissue oxygenation. Right. So let's go through one at a time. Hemorrhage control. So we classify hemorrhage control we divide this into two halves. Is the patient bleeding from an extremity, or is it three parts really? So from are they bleeding from an extremity or extremities? That's number one. Are they bleeding from the junctional areas, groins, axillae, neck? That's number two. Are they bleeding in a non-compressible area, which is torso? So are they bleeding from the extremities? Are they bleeding from the junctional areas? or are they bleeding from the torso? You divide the groups into 3. If they are bleeding from extremities, it's very easy to control the hemorrhage. The first thing you would do is apply external pressure. So, for example, this person is bleeding from the forearm. You take a Gamgee or a pack of gauze and apply firm pressure on the site of bleeding. Firm pressure for about 10 minutes to stop the bleeding. That's the first thing you will do. The second thing you can consider is focused arterial compression. For example, for this person, they are bleeding from the forearm. You can press on the brachial artery to reduce the amount of bleeding. The focused arterial compression can be done. Sometimes it can be a little difficult, and it can take a bit of force to reduce the bleeding, but it does work, especially if there is a sputum. The third one, especially useful if there is traumatic amputation or near amputation of extremities, is the tourniquet or the windlass tourniquet. The tourniquet can be custom made like you see in this picture, or windlass, which I will show you in a minute. So, tourniquet, basically this is just clothing material with a piece of wood, that's all, a stick. You tie it tightly round the limb and you tie the clothing to the wooden stick, make a knot, and then you start rotating the wooden stick until the tourniquet is tight enough, and then you tie the cloth again. So it's cloth, wood piece, keep rotating the wood piece until you achieve control of hemorrhage, and then tie the cloth again. So that way you can achieve good hemorrhage control in completely amputated limbs or near amputation or exsanguinating hemorrhage from the limbs. This is just a custom-made device that's used on both sides, but this is from the ATLS manual. Here they have used the windlass device, which is a self-applicable tourniquet, very easy. You put it through the arm, you start twisting the rod that you can see here until you achieve control, until it's tight enough to stop the bleeding. And then there's a clip device that keeps the rod in place and does not allow to untangle, and there's a Velcro on top of it. So you see this trauma victim is being resuscitated. He has a windlass on the left and a windlass on the right, which is partially seen. So that's for extremity amputations. What about pelvis? Which I just showed you an open book fracture of the pelvis, and I mentioned that it's important to close the pelvis to reduce the bleeding into the pelvis. So you apply a pelvic binder, and this is a local device that's available. But if you do not have any pelvic binder devices, you can just use a normal bed sheet. We could have used this purple bed sheet to tie it around the pelvis. It goes on the greater trochanter and not on the anterior superior iliac spine. The common mistake people do is they put it on the anterior superior iliac spine. So it's important to remember that if you're going to use a pelvic binder, you have to put it on the greater trochanter, and it should be tight enough, and then only you will achieve closure. And final thing is you can splint. We have all seen this. I'm not going to put a picture. So Thomas splint or extremity splint. By splinting the bones, you reduce the volume into which the patient can bleed into. So this is extremity area, compressible area. Non-compressible areas, groins, torso, what can you do? So you can, if it's a laceration, so for in the groin or neck or axilla, you can pack the wound with gauze or Gamgee. So pack the wound really nicely and then apply firm pressure over that for 10 minutes, it will stop the bleeding. If it's intra-abdominal or intrathoracic, you can use the Reboa device. It's very, very simple. This is an anesthetic forum. You all have seen or read or heard about anesthetizing patients who come in with ruptured aortic aneurysms, one thing that the surgeon does is open clip the aorta to get the hemodynamics. So basically, if you clamp the aorta, the hemodynamics improve. It's the same principle. Patient is bleeding into the abdomen or pelvis, into the torso quite profusely. You put a catheter through the femoral artery and you inflate a balloon into the aorta, which acts like a clamp that is applied externally, and it allows the hemodynamics to stabilize, and it gives you time to resuscitate the patient. So that's REBOVA. And finally, if you see an exsanguinating hemorrhage, you just have to call the surgeon or the intervention radiologist to stop the bleeding for you. So the idea is stop the bleeding while you simultaneously restore the lost volume. So coming to the restoration of the lost volume, the theme is the same, like AB mentioned about all these studies already, and many of them hold good in trauma as well. Restoring the volume, your first choice is going to be crystalloids, and the choice of among crystalloids is balanced crystalloids to start with your Ringer's lactate. That's what you would use. Ideally, warmed Ringer's lactate, 1 liter. So, I mean, quite often in our country, at least in southern part of India, you don't necessarily need to warm the crystalloids because the room temperature quite often is not that low. So you can use Ringer's lactate straight from the shelf and you administer. The teaching is you have 2 lines in both the antecubital fossa, and you administer 1 liter of Ringer's lactate to start with, reassess the patient, and then decide whether they need more or not. Alternatively, you can use normal saline. Talk about when we would prefer normal saline than crystalloids. What about all these other fluids that are available? The synthetic colloids like Dr. Ebi mentioned, hydroxyethyl starch, your Vol-1, Vol-lite, etc. Dextrons are available, gelatins, your Hemaxil is a gelatin. They're available. Albumin is available. Hypertonic saline is available. Bicarbonate is available. So we tend not to use them for initial resuscitation of a hemorrhaging trauma victim. So it's crystalloids, crystalloids initially, right? Okay. So warmed oral, this is what I talked about, fluid of choice in all the trauma except when there is head injury. So we prefer normal saline for traumatic brain injury, and the initial volume is 1 liter, and you reassess constantly. It's important to remember that there is no point in, you cannot keep pouring crystalloids after crystalloids. You have to keep reassessing, order blood early if required, and avoid fluid overload. This was talked about in the septic shock talk as well before. The same theme continues. Whenever you resuscitate shock, you give some fluids, you reassess. I mean, Dr. Ebi mentioned about a few parameters that we look at. And last week, you had an extensive session on how you assess fluid volume and what we use what are the contemporary techniques that we use nowadays to assess somebody's fluid volume to give more fluids. So important to start off with crystalloids, keep assessing. If the patient is continuing to bleed, use blood. That's all. The same studies mentioned by Dr. Ebi, SAFE study, which compared normal saline and albumin basics and plus other new ones. So Ringer's lactate is good for general trauma. If there is a suspicion of head injury, use normal saline, because normal saline contains more sodium compared to Ringer's lactate, and the osmolality is slightly higher, slightly hyperonchotic. So it is helpful in patients with traumatic brain injury. It's not going to prevent your cerebral edema, but at least, you're not using a hypotonic fluid and you're not potentiating the cerebral edema. So why not colloids? This has already been talked about. Colloids, if you use colloids in a shocked victim, it increases the need for renal replacement therapy in intensive care. It increases the risk of multi-system organ failure, and it increases the mortality. So on the first do no harm principle, you will not use colloids while resuscitating a trauma victim. And I'm not going to talk about the same thing that AB mentioned, the 1:4 effect that you all have read in the books, like you have to give volume by volume colloids or volume lost to 4 times the volume of crystalloids is refuted by all the trials. So that theory does not hold good, and it's a theory, it's a physiological concept, and it doesn't happen like that in clinical practice. So that does not hold good, and we do not use colloids. Synthetic colloids are associated with higher mortality, both in sepsis, critically ill, and in trauma patients. This is an interesting trauma registry analysis where they had looked at about 48,000 plus patients. If you see from 2002 to 2015, the use of colloids has gone right down clearly. And the ISS is injury severity score. I will not go into the details of it. This tells you about the severity of trauma, and we use it as a treatment tool, as a prognostic tool, etc. Severe trauma, some of them still do get it, but majority of the mild and moderate, they don't. So overall, the usage has gone right down. And very interesting to also to note that overall fluid that has been given to the trauma victims over that 13 years period has come down as well. So if you look at it, the average fluid given was about, I don't know, in severe trauma, we have been using about 4.5 liters in 2002, and now we are using half of what we were using in 2002. So the practice is changing. We are giving less volume, more blood, less crystalloids, more blood, number one. Number two, we are kind of completely stopped using colloids in trauma. So avoid colloids, that's the bottom line. How about albumin? So albumin as a fluid is exciting. It's human, it's not synthetic, and it's readily available as well, at least in our country. 4% albumin, if given in trauma, can increase in intracranial pressure. So at least one study, the SALT TBI analysis, which is a sub-study of the SALT trial, showed that the raised ICP was the main reason for the higher mortality in patients with traumatic brain injury, head injury. So albumin is contraindicated. I will not say don't use, not beneficial, etc. It's contraindicated in patients with traumatic brain injury. That's it. So non-TBI, it's pretty similar to crystalloids. There is no difference between crystalloids and albumin. So you might not want to use it, because one bottle of albumin is about 6,000 rupees. A bag of crystalloids is about 120 rupees. So if they two are equal, you might as well choose the cheaper one when you resuscitate and not the most expensive one. There's absolutely no role for albumin in trauma. Unlike sepsis, where Dr. Ebi mentioned, you give crystalloids, and if you think they're going to need more and more, you might want to consider albumin. No talk of that in trauma, no albumin. Right. The third concept, quite an exciting concept when I was a trainee back in 2003, hypertonic saline, the low volume resuscitation was a concept that we were quite fond of in 20 years ago. You give hypertonic saline, think of the physiology, it pulls all the fluid from the tissues, it improves the intravascular volume. You're giving a low volume, the physiological effect improves the intravascular volume and improves the hemodynamics. So that was once again a physiology, an academic concept and a theory. But unfortunately, none of the studies have shown that this low volume resuscitation concept was beneficial. So I wouldn't be using hypertonic saline as a resuscitation fluid or for the low volume resuscitation or small volume resuscitation concept. But for traumatic brain injury, yes, I will give hypertonic saline as an osmotic agent. That's different from resuscitation. I will not use it as a resuscitation fluid, but I will certainly use it as an osmotic agent in traumatic brain injury. Right. So that's about hypertonic saline. So we talked about crystalloids. That's what we will be using. We will be giving 1 liter of Ringer's lactate as the starting fluid. We will use normal saline in suspected head injury. So essentially in our trauma bay, we give normal saline as the first fluid, because you never know who's got head injury, at least when they are rushed into the emergency department. We do not give colloids. You have to remember that some of the countries have taken colloids off the shelf. United Kingdom is one of them. If you're going to go and work in the UK, you cannot find any of the colloids, volume, volulite, hemaxil, gelatins. None of them will be available for your use because I won't say it's banned, but it's taken off the shelf for safety reasons. If another country removes a substance for safety reasons, I don't think we should be using it. So that's about colloids. And then hypertonic saline, we talked about. Albumin, we talked about. Finally, bicarbonate infusion. It's quite an interesting concept. People think that, when I put the table on the classification of hemorrhagic shock, one of the pointers is the base excess, and how much acidosis there is in the patient. And the concept of bicarbonate infusion came about. As the acidosis sets in, as the shock worsens, acidosis becomes worse and worse and worse. How about giving bicarb to correct the acidosis? And we're going to talk about the triad of death in a minute anyway. So that's why this concept came about. There's absolutely no benefit as a resuscitation fluid. It can cause paradoxical acidosis. You can look it up, what paradoxical acidosis is. It's a theoretical concept. It has been questioned. We don't know whether the paradoxical acidosis intracranial exists. There's no great evidence that bicarbonate helps in trauma resuscitation. And if you start giving bicarbonate, you don't know how much to give initially. So it's a trial, and then you give some bicarbonate, you check the acid base. If the patient has become alkalemic, the calcium might fall further. So we really don't know what the effect on calcium and the other electrolytes will be, and how much volume to give. You're going to give bicarbonate. So it's not useful as a resuscitation fluid. Do not use bicarbonate infusion as a resuscitation fluid. But boluses of bicarbonate, small, just like hypertonic saline, you can use boluses of bicarbonate as an alternate therapy for raised ICP. Remember, bicarbonate contains a lot of sodium. It's a hypertonic solution, contains a lot of sodium. It's pretty similar. In fact, it's even better than hypertonic saline in some situations. It is useful in traumatic brain injury if you do not have hypertonic saline. But if you do have hypertonic saline, that is preferable. Right. So that's about the fluids. So far we've talked about hemorrhage control, our goals of resuscitation, about what we're going to use to resuscitate a patient: crystalloids, colloids, albumin, bicarbonate, etc. Now we're moving on to trauma-induced coagulopathy. So it's an interesting concept. So what really happens in trauma? Why should we be worried about giving early blood early? Why do we need to order products, etc.? For that, we need to understand a little bit about trauma-induced coagulopathy. I will not go into the details of it. There are lots of papers available with beautiful pictures to make you understand what thickest trauma-induced coagulopathy is. But this is just a basic picture showing what happens in trauma. As soon as you suffer an injury, there is tissue injury. The substances get released because of tissue injury. Plus, if you bleed, you're going to be in shock. Your tissue perfusion is affected. These two will lead to damage of endothelial glycocalyx. So inside the vessels, the endothelial layer has glycocalyx layer that gets damaged, and because of that, there is platelet dysfunction, there is fibrinogen depletion, and there is increased expression of APC. So the endothelial glycocalyx disruption leads to increased activated protein C. There is also platelet dysfunction from the mediators released from the tissue injury, and there is fibrinogen depletion. This is an endogenous response. So trauma injury leads to APC release from the damaged glycocalyx, platelet dysfunction, and this depletion of fibrinogen. That leads to the increased APC and the release of heparan sulfate leads to autoheparinization, which is anticoagulant, hyperfibrinolysis, which is again leads to bleeding, reduced clot strength, fibrinogen depletion, reduced clot strength. Once again, the clot does not hold and patient bleeds, reduced thrombin formation. So it leads to acute traumatic coagulopathy. So that's, in a nutshell as to what happens. Tissue injury, your platelets are not working well, your fibrinogen is less, you have autoheparinization. On top of this, if you pour more and more crystalloids, you will dilute the coagulation factors further, and that will lead to further depletion of coagulation factors, including fibrinogen, and that leads to worsening of the coagulopathy. So this is trauma-induced coagulopathy in a nutshell. So, this is something that we've all heard about, read about often. In trauma, the major problem, not just in trauma, any patient presenting with shock, the major problem is this lethal triad, which is acidosis, coagulopathy, and hypothermia. When there's hemorrhagic shock, the tissue perfusion is affected. When the tissue perfusion is affected, there is anaerobic respiration happening in the tissues because of lack of oxygen, and there is acidosis. And if you're not careful enough, patient becomes hypothermic for two reasons. One is, they're not covered well enough. Number two, the skin perfusion is going to be less because of the vasoconstriction. So there's going to be a loss of temperature. So this hypothermia, number two. And we just talked about trauma-induced coagulopathy. So the coagulopathy also is affected by the acidosis and hypothermia. And it's a kind of a vortex that you get into. Acidosis potentiates coagulopathy, hypothermia potentiates coagulopathy, and the patient gets into a vortex. It's important to get the patient out of the vortex. So you have to be proactive in preventing this lethal triad. We used to talk about lethal triad, but now this concept, I'm not entirely sure whether that has taken up, and I don't believe in this concept, but it is available for you to read about. The concept includes calcium as well, and they've changed the triad to a tetrad or a diamond: acidosis, coagulopathy, hypothermia, and hypocalcemia, especially when you are using lots and lots of blood products. I couldn't find any major evidence for this lethal diamond, and I don't believe in it, but it is available, as I mentioned. This is one of the retrospective single center reviews that included about 7,500 patients. And what they found was hypocalcemia was an independent predictor of mortality with an absolute odds ratio of 2.7. And this is kind of one of the papers that drove the concept of tetrad, or the lethal tetrad, or the lethal diamond. Right. So the whole idea of resuscitation, as I mentioned, apart from hemorrhage control and filling up the patient back, is to prevent the patient getting into this vortex of this lethal triad. So moving on to blood and blood products. So far we talked about fluids, crystalloids, colloids, what we prefer and what we don't. Moving on to blood and blood products. It's very clear. I think I've mentioned this more than enough during the last half an hour or so, that give blood early. So that's the mantra in trauma: give blood early. They are bleeding, give blood. It should be replaced. Blood should be replaced with blood. How do we decide who is likely to need blood? There are several scoring systems that are available. We use this simple ABC score. Is that the penetrating mechanism of injury? Is there a positive fast? Are they hypotensive? Are they tachycardic? That's all. Tachycardia, hypotension, positive E-fast, penetrating mechanism of injury, high possibility of them needing blood if they score 2 out of the 4. MTP is massive transfusion protocol, high possibility of them needing lots of blood. So you might want to activate the massive transfusion protocol in your hospital. As I mentioned before, the class 3 and 4 shock patients are likely to need blood. So that's simple scoring system to predict who is likely to need blood. So when we talk about blood, what do we give? So we have so many blood products. So we have packed red cells, we have FFP, we have platelets. Of the platelets, we have single donor platelets, we have random platelets, we have cryoprecipitate, etc. So what do we use? Ideally, you should be using PRC, packed red cells, FFP, and platelets, all three together in a 1:1:1 ratio, which means you give a unit of blood, which is the third number, you give 1 FFP and 1 platelets. So there was a trial called Proper Trial that looked at, so that's a lot of blood products. So I'm going to order blood products. I have to order 2 blood, 2 FFP, 2 platelets. That's a lot of blood products, and it may be difficult to get hold of so many products in at any particular point in time in some situations and in some places. So is there a possibility that we could use less plasma and platelets compared to blood? Can we give more PRC, less plasma and platelets? And that was the Proper Trial, and that's what they tested. They didn't find any difference in mortality at 90 days, which led to the conclusion that, yeah, maybe you can use more PRC, less plasma and platelets, but the trial was hugely underpowered. And there was some suggestion that the 1:1:1 ratio worked really well. So throughout the world, 1:1:1 is still widely used. And even the young boy that we resuscitated 3-4 days ago received 4 units blood, 4 units FFP, and 1 apheresis platelets. So when I say 1 platelets, what I mean is single donor apheresis platelets, 1 unit. If you are using random, you have to remember that 1 unit apheresis is equal to 6 units of pooled platelets. That's something that you must remember. So if you're ordering, depending upon where you work, your massive transfusion protocol might differ. Generally, across board, if you're going to ask for blood and you say that it's a massive transfusion situation, you will be given 6 units of blood, 6 FFP, and you will be given 1 apheresis platelets. So that's all good. So 1:1:1 is the ratio that we are using, and we are going to give blood early. So what about whole blood? So whole blood as a product, some of the seniors might remember that it was the only product that was available when we were in the medical college. Those days, component separation was difficult. The technology was not available in India. Equipment was not available. Only a few centers had it, etc. I still remember as a CRRA, whenever I entered my blood bank, the first the notice that you see on the blood bank door was husband's blood cannot be transfused to the wife. So that was the notice that was put up in our blood bank at Chennai Medical College many years ago. But the whole blood concept is making a comeback. If you think about it, whole blood contains not only PRCs, but also all your coagulation factors and platelets, and it makes sense to give the whole blood in a trauma victim, but it's still not widely practiced. But if you do have whole blood available in your hospital, you might want to use it. So the whole idea of talking about blood is give the blood early. So how do you administer blood? Ideally, you would want fully cross-matched blood, but then the limitation is cross-matching takes about 45 minutes to an hour. You may not have the luxury of having time during trauma resuscitation. So if the patient is exsanguinating, use O negative. So start with O negative blood, and then as soon as you get type specifics, for example, I'm B positive, without cross match, can you get B positive from the blood bank and transfuse? That's type specific. So type specific blood is safe. Several studies have shown that type specific blood without cross match is reasonably safe. So type specific blood you can get hold of very easily, quickly. And if you're going to use AB plasma if you're going to use plasma without cross match, you can use AB plasma. Just get AB plasma and put it on a patient as part of your ratio. Blood, O-neg, AB plasma, you can administer. Important to remember, women of childbearing age use RH negative if possible. Right, that's about blood administration. Once again, the concept is give the blood early. One slide on access. I know there was a question on access as well for the previous speaker. In trauma, you want to have a large bore short cannula in the antecubital fossa. I will not go into the physics of why you should have large bore, why it should be short. I mean, I'm sure you all have read about the Hagen-Poiseuille law. If the cannula is larger and shorter, the flow is better. So I would rather, if I am the trauma victim, I would rather have an orange or a gray in my antecubital fossa than a slender, long central line in my neck for my trauma resuscitation. If you cannot find a peripheral line, the young boy that we received last week, we couldn't find anything. He was exsanguinating from his scalp. So an intraosseous needle was placed in the left leg. We resuscitated him with that intraosseous needle until the hemodynamics improved, and then we placed a femoral sheath. So when I say sheath in the subclavian vein or femoral, I'm not talking about the central line. I'm talking about your PA sheath, the cordis sleeve, or a dialysis line, which is a large bore line. You want a large bore line in a large vein so you can transfuse products and crystalloids quickly. So that's one slide on venous access. So we talked about fluids, we talked about what to give, what not to give. We talked about blood. So if the patient is exsanguinating, it's O negative. Your ratio of blood FFP platelets is 1 to 1 to 1, and the 1 is random. So 6 random is equal to 1 apheresis. Remember that. If you cannot get hold of cross-matched blood, you can take type-specific blood and administer. It's reasonably safe. And then you preferably use a large bore peripheral cannula. Next, some of the medications. I'll touch upon the medication, just 2 slides or 3 slides on them. Tranexamic acid, you must administer. It should become the standard of care. Tranexamic acid must be administered in all hemorrhaging patients within the first 3 hours of presentation. It has shown to improve outcomes in trauma. So you give 1 gram within the first 3 hours. If given beyond 3 hours, it increases mortality. So it's important to give it as early as possible. That's number 1. And you can continue the tranexamic acid as an infusion over the next 8 hours. That's about tranexamic acid. You must administer tranexamic acid. And the trial that showed benefit was the CRASH 2 trial. If you're interested, you can read about it. Second, calcium. As I mentioned, the triad is becoming a tetrad now. Not much of an evidence, but there's some suggestion that we should give 1 to 2 grams of calcium chloride or 6 grams of gluconate every 6 units of PRC. But ideally, what I do in my practice is I check the ionized calcium, and if it's low, I give calcium. That's the way I do. I do not, by default, give calcium for every 6 units of PRC. The next is fibrinogen target. So we mentioned that there are 2 problems. One is we talked about trauma-induced coagulopathy. In that, we said if you give lots and lots of crystalloids, you're going to deplete the coagulation factors. And one of the factors that get depleted is fibrinogen. It's important to replace the fibrinogen to achieve better hemostasis. So cryoprecipitate is the product that gives you enough fibrinogen. Ideally, you would want to give 10 units of cryo to increase the fibrinogen by 75 milligram per deciliter. Your target is 150 to 200 milligram per deciliter for better hemostasis. Nowadays, there are commercial fibrinogen concentrates that are available. They are a little bit more expensive. If you do not have access to cryo in your hospital, then this can be definitely considered. It will be useful. Fibrinogen, because for me, if I am the trauma victim for a 70 kilo male, it will cost about 10,000 rupees, the fibrinogen concentrate, to keep the fibrinogen level at 200. Okay. What about RF7A, exciting product? We talk a lot about it, but we use very less of it. It's an off-label indication in trauma. So as a suggestion, after the 8th unit of blood, you can give 200 microgram per kilo followed by 100 microgram per kilo 1 and 3 hours later. It can be used, but it's remember that it's an off-label indication. Also, the local hemostatic agents. I mean, you're all anesthetists. You all know about these things: Surgicel, Caltostat, Flow Seal, topical thrombin, gel foam, Tizil. They're all local hemostatic agents which the surgeons use routinely in your theaters. They can be used on open wounds to reduce bleeding from the wounds. So that's about medications. How does tranexamic acid work? It's prevents the conversion of plasminogen to plasmin. Plasmin is important for fibrinolysis. So basically, it's an anti-fibrinolytic by preventing the conversion of plasminogen to plasmin. And these are the 3 trials that one would want to to read about crash 2 in traumatic brain injury, crash 2 follow-up. And the woman trial, I'm sure all the anesthetists will know, for postpartum hemorrhage, tranexamic acid is very useful, right? So what are my targets? So yeah, okay, I'm giving fluids, I'm giving blood, and my aim ultimately is to improve the tissue perfusion. But what are my intermediary targets? I don't want the patient to get into the vortex of the lethal triad. That's the #1 target. I would want to prevent fibrinolysis by giving tranexamic acid before my products. I want to substitute oxygen carriers by giving RBCs. I want to substitute coagulation factors by giving FFP and fibrinogen. I want to give platelets and possibly thrombin burst by giving RF7A. So those are my kind of targets, if you like. So one slide on viscoelastic testing guided resuscitation, your ROTEM and your TEG, not widely available, but as a concept, we do read about it. But I don't know how many centers have it in India. I really don't know. But I mean, I'm sure you all have seen the pictures. It's important to remember that the viscoelastic testing is very useful if available. If you use VET, you will be giving fewer units of blood. You will have better hemostasis, no doubt, and there is improved survival. There's some suggestions, some trials showing that this improves survival with TEG-ROTEM guided resuscitation. None of your conventional, this is based on the concept that none of your conventional tests pick up hyperfibrinolysis. So TEG picks up hyperfibrinolysis, which is very useful in trauma, right? Couple of slides on permissive hypotension. So higher blood pressure does not necessarily mean better perfusion. So you need to keep this in mind. BP and flow are different. Pressure and flow are different. Higher blood pressure will lead to the clot getting dislodged. So in trauma resuscitation, you have to allow permissive hypotension. We aim for a systolic blood pressure of 90, or I've been taught, have you resuscitated to a radial, which means a patient is coming in without a radial. I've resuscitated the patient. Now I can feel the radial. That's good enough. Systolic blood pressure of 90 is good enough. Or if you're following MAP, 60 millimeters of mercury is good enough. If the patient has brain injury, you would aim for slightly higher, 100 or 110 millimeters of mercury. And this has been shown to improve mortality. So permissive hypotension is the other concept that we look at in trauma when we resuscitate. So putting it all of them together, so this is what is called damage control resuscitation. So far, what we've talked about is damage control resuscitation. So a trauma victim that is exsanguinating, the first thing you do is you stop the bleeding. #1, rapid anatomic control. You administer tranexamic acid. You find out, do an e-fast, find out where they are bleeding into, and see if you can fix that. Give the crystalloids initially, but limit the crystalloids. Administer blood products early in a 1-to-1-to-1 fashion, and allow permissive hypotension. And that is what is called damage control resuscitation. If you follow all 6 arms of the damage control resuscitation, your outcomes will certainly be better. So I'm resuscitating my patient. How do they respond to my resuscitation? So do they respond differently? That's how I should put it. So I'm resuscitating somebody in my trauma bay. Do they respond in a different way? So yeah, depending upon the degree of trauma, some of them are called early responders, which means, I've given them a liter of Ringer's lactate. Their hemodynamics normalized. They are called early responders, which means, the bleeding has stopped, or we have controlled the bleeding. For example, scalp hemorrhage stopped, 1 liter of Ringer's lactate given, hemodynamics normalized. That's an early responder. Transient responder means I'm giving fluids. I see a response after 5 or 6 minutes. They once again become tachycardic. Once again, they show features of shock. The pulse pressure goes down, and even they become hypotensive. They call transient responders, which tells me that there is an ongoing bleed somewhere which I have not identified, or there is a generalized coagulopathy. They've gotten into trauma-induced coagulopathy. I need to get them out of the vortex. Important to find out where the source is and continue the damage control resuscitation. There are non-responders. So my patient has a liver laceration and they're bleeding profusely into the abdomen. The splenic artery is cut off. The pelvis is completely broken. The femoral artery is cut off, etc. Our aorta is leaking. They are non-responders. No matter how much fluid you give or blood you give into them, you will not be able to resuscitate them simply because they are there's an ongoing bleeding. So for these kind of patients, you will consider the Rebova that we talked about early, take them to ER, explore early if possible, or intervention radiology plus theater. So this should be OR, not ER, OR, operating room, and intervention radiology, and a team approach will certainly be able to stop the bleeding and resuscitate the patient. So, so in summary, that's a lot of slides and a lot of information. So in summary, the bottom line, whatever you want to call it, use crystalloids, but limit its use. Give blood early, aim for a hemoglobin target of 7 to 9 gram%. Give tranexamic acid within 3 hours of presentation. Permit hypotension till the source or the bleeding source is controlled. Prompt and aggressive source control. You ask your surgeon or get the help of IR. Remember the pressure pack concept, pressure pack tourniquet concept. Try and avoid the lethal triad, get them out of that vortex. I don't know whether it's a tetrid, but I still go with the triad for now. Consider the adjuvant medications and products if required. Thank you.
Devachandran sir, it was lengthy. There are a lot of slides, but very, very useful, sir. I think everyone who works at the casualty and a trauma center have to know from every state of this presentation. It was very nice, sir. Thank you very much, sir. The first question is on how albumin causes traumatic brain injury.
No, albumin does not cause traumatic brain injury, sir.
No,
albumin,
sorry.
Yeah.
Why it does? It should not be. Sorry.
Yeah. No, yeah, I understand the question, sir. Albumin seeps out into the brain tissue and increases the oncotic pressure in the tissue and increases the intracranial pressure.
Okay. Why shouldn't? Can we use 20% albumin instead of 4%?
The same thing happens, sir.
Okay, sir.
Basically, we're talking about blood-brain barrier disruption.
Yes, sir. How to maintain temperature in trauma patients, sir?
So warm the crystalloids, warm the blood. So that's unfortunately, as a concept we don't practice in India. Blood must be given through a warmer because it comes from the fridge. It must be given through a warmer. In some countries, they put it in the microwave and heat it, but then that is not a good practice. If you overheat it, then it will get cooked. So it must be given through a blood warming set.
Okay. I think I have not seen one blood warming set, sir.
It's not widely.
Do we have one? Okay, sir.
Every hospital might have one.
Okay. About pregnancy and trauma, there are two questions, sir. Any modifications apart from LUD in pregnant patients with trauma, sir, and others on trauma and pregnancy?
Sir, apart from what, sir? Any modifications?
From LUD. Any modifications apart from LUD in pregnant patients?
So, I mean, the uterine displacement is what they.
Yeah, lower.
I think.
I think the question is from Sarva. Sarva, he is online. Sarva,
the question is like any other modification apart from left uterine displacement be done in patients with.
Okay.
Yes, madam. There are lots of things that you will remember and think about when you resuscitate a pregnant lady, from the position of the chest drain to how anatomical. Basically, all of them are anatomical. But the bottom line is treat the mother. Treat them like any other victim. Yeah.
Okay.
I think a question from Dr. Praveen Kumar, the ideal fluid of choice in trauma resuscitation. I think it is well answered in the session itself,
I think I mentioned it so many times, sir.
Yes,
normal
sir.
saline
Yes,
is what I use. Yeah.
Okay, sir. Very, very nice, sir. Thank you very much for this enlightening presentation, sir. I think both of you together have crashed the concept of colloids. Totally, I think from now postgraduates will think twice before they use colloids. Okay, sir. And that was a very nice session. Coming to the end of session. Thank you for both the speakers for coming here, spending your time and giving us such a nice presentation. And I thank all the viewers, the postgraduates, the consultants who are there in the online anesthesia with us. Thank you all. Thank you very much. Okay, we can end the session.
Thank you,
sir.
Thank you.
Thank you.